You quit talking and actually finish the survey.
I can't focus.
We're reading.
Seriously, he's talking to me. I got done.
I should have went. Nice neutral.
Can't quantify it, depends. Hello. So he doesn't get a survey, let's do it. Alright, I'll slowly get started here. For starters, thanks for all 10 of you for coming out. It says a lot that you guys would stay after school to learn a little bit more, so hopefully I don't let you down here. But yeah, the survey, please don't put your name on it. Just indicate like what trimester you're in, or if you're in multiple trimesters, indicate like what year you'd be, first year, second year, third year. And then you'll take the same survey at the end of the presentation. And I'm just going to collect the data and maybe write up a quick little paper on how I altered your perceptions. So this talk is something I've been working on for like over 2 years. This is pretty much everything I've been reading on my own time, all combined into one talk. It's kind of multiple topics, so it's going to consist of these modules. Just a forewarning, it took about an hour and 30, hour and 40 minutes last time I practiced it about a week ago. But I decided to omit a couple sections, so we'll be a little on the lower end there. But hopefully it's worth your time. We'll talk about the biopsychosocial clinical model. You've all heard about it. I'm just going to go a little more in depth or give my twist on it. The physiology of acute pains, we'll just learn about what pain is, how it works, and then we're going to differentiate that from chronic pain and how they're alike, how they're different. And then risk factors for chronic pain, how it comes about, how an acute injury can become chronic, and then how to manage these conditions. So if you aren't aware, like I'm in Tri-9 right now, I'm working at Affinia Healthcare, which is under Dr. Battaglia, the Tri-5 imaging professor. He's a wealth of knowledge, but we see a lot of people who would be considered low socioeconomic status, so very underserved, underinsured people, so a very high prevalence of chronic pain disorders. So I did include a few case studies from what I've seen in the last like 16 weeks, and hopefully there's there are moments for me that I took away a lot from it and learned and made me a better clinician, so I want to pass that knowledge on to you. All right, so starting with the BPS model, first we have to learn about what was in place before the biopsychosocial model. So before biopsychosocial model was a thing, we knew about it, we operated under the biomedical model or the pathoanatomical model. And the three assumptions of the biomedical model was that all illness had a single underlying cause. There was some form of disease or pathology, and it's always like one lesion or one cause, and that if you could just remove this single cause, that you restore optimal health, and it was that simple. But it turns out it's not that simple, and these early doctors were wrong. So the first time we started questioning this was when soldiers were coming home from war, as you can see in this picture here. Maybe he has no infection, he has no fever, he has no signs of visceral dysfunction, but he does not look like pure health in this picture. So we knew there was something else that these patients were bringing back with them that were not really organic. There was nothing you could test in the blood or in the body. You couldn't find any physical cause for their ailments. So I kind of want to relate that to the chiropractic philosophy that we were all founded upon, is that, you know, back pain is caused by, use whatever term you like to use, subluxation or motion restriction or whatever else there is, I forgot the rest of them. But we operated under the same assumption, is that if you have pain, there's probably a joint that's not moving, and that you need to, you know, get the joints that aren't moving, or you need to get the ones that are moving too much to not move so much. But this is straight out of Netter's orthopedic assessment, that there is no correlation between motion fixation and back pain. So I thought this was a really good quote here. Motion restrictions were no more prevalent in people with current or recent back pain than in those who had never experienced back pain. So it's just this isolated finding that we correlate with the rest of our clinical presentation. But just want to kind of give you that reminder that this isn't just in allopathic medicine. This isn't just infectious disease, but we see the same thing in chiropractic care. So Francis Peabody, 1927, he was one of the first people to speak on there's something more to patient care than just finding the disease and removing it. I'm not going to read every slide word for word, but these are 3 really awesome quotes that I do want you to take the time and read. So the first one, young graduates have been taught a great deal about the mechanism of disease, but very little about the practice of medicine. Or to put it more bluntly, they are too scientific and do not know how to take care of patients. He also said, the significance of the intimate personal relationship between physician and patient cannot be too strongly emphasized. For in an extraordinarily large number of cases, both diagnosis and treatment are directly dependent on it. And then this last one, there's no more contradiction between the science of medicine and the art of medicine than between the science of aeronautics and the art of flying. And then from the speech he gave, this is one of my favorite quotes as far as motivators that drive me in my career, is that the secret of the care of the patient is in caring for the patient. So Peabody was one of the first people to start bringing this topic up and getting people talking about, okay, there's something more to, you can't just identify A, give them pill B, and eliminate the cause. But you really have to develop a relationship and care for the person. So the biopsychosocial model has predominated healthcare since like the 1960s, give or take. And this figure is from a paper written by a bunch of Logan grads. But I'm sure you've heard it before. Given this presentation, I just want to go a little more in depth with it, take the time, talk about it, kind of make sense of how all these things are connected. But general principle is that there are biological processes that can cause pain or ailment, and then there's the psychological state of the person, and then there's also the sociological influences on them. So an example of each: biological could be the tissue health. Is there tissue damage? Psychological, do they have a psychological disorder, or are they depressed or anxious? Sociological, where do they fall in as far as like what kind of jobs do they have, what relationships do they have friends and family to talk to? So in these next few slides, hopefully I'll connect the functions between these 3 pillars and make sense of it all. So to start, Dr. Apkarian, who's, if you ever talk to Dr. Kettner about him, he refers to him as his nemesis. He's always a few months ahead on publications. They look up the same stuff, and yeah, they're identical people. But favorite quote from his paper: depression is ranked as one of the strongest predictors for low back pain. That should come as no surprise. So let's look at the links. How many depressed people, let's reverse that. How many people in a pain state have depression? Anywhere from 30 to 100, pretty widespread. How many people with clinical depression experience pain? Up to 100%. So look at that however you want. It's a pretty large range, but there's no denying that there is a correlation between psychological systems and biological. This is a really cool study. It's only like 2 or 3 pages long, so you guys can read this, I promise. But does rejection hurt? An fMRI study of social exclusion. This one really opened my mind up a little bit. So what they did was they took this subject and they said, hey, we're gonna scan your brain in this functional MRI machine while you're playing a video game. And they told this subject that there's 2 people in different MRI machines. They're in a different room. You'll meet them later. You're all gonna play a video game where you just play catch with each other. What this person doesn't know is that the other 2 people are just computers, and they programmed it to where after they're playing catch for a while, the 2 computers just start throwing back and forth to each other, and that human's just sitting there like left out, like they're not throwing them the ball at all. And so what they did was they simulated social rejection or social exclusion while scanning this person's brain, and the areas they saw that lit up primarily were the DACC, which is the dorsal anterior cingulate cortex. This is known as like the brain's alarm system. So its primary function is monitoring for anything wrong in the environment. And so they noticed that this is the same area that lights up when you're experiencing emotional distress or if you're experiencing physical pain. It's just the alarm that goes off. So as a reminder, in the pain pathway, there's a lot of different brain areas and pathways that contribute to the pain experience, but you can see right in the center is the anterior cingulate cortex. That's that DACC. So activity rises when there's physical pain and when there's social rejection or social exclusion. Just when you thought you were done with the neural book, I just wanted to show you again the same thing. If you remember, we had like the spinothalamic tracts with the 3 different divisions, neo, paleo, and spino-reticulo. We had some that, went up to S1 and told you, okay, I hurt right here with this intensity. But then we had other components of the pain pathway that, synapse-on reticular formation cause you to wake up, pay attention, what's going on. And then they go up to these affective and cortical arousal areas of the brain. So there's feeling the pain, there's knowing the amount of pain that you currently are experiencing, and then there's the emotional effect of pain. Another quick study. So this was done on monkeys, but it was pretty crazy the results they got. So they took a bunch of monkeys who were just living in captivity the way they do, and if you know, like monkeys have really social roles, like there's the alpha, and everyone has their own role in their community. They caused chaos. They separated monkeys apart. They would put them in different cages. They would, wouldn't let them see their brother or girlfriend or whatever. So they did everything they could to just cause social instability. And then they measured their urine metabolites for things like catecholamines and stress hormones. And what they found was a pretty drastic effect on stress hormones in their blood and in their urine whenever these monkeys were separated and madness everywhere. The cool thing about the study, though, is as soon as they returned them back to stable conditions, back to where they wanted to be, that these blood biomarkers they disappeared pretty quickly. So the takeaway was that social instability, even though it causes this really big stressful alarm in the body, it's very easily reversible. Second time they did this, they did the experiment twice. The second time they did it, they said, okay, well, what are these elevations in stress biomarkers? How do they compare to, I don't know, if we just took an IV and gave them meth? Turns out the social instability was drastically higher in its effects on elevating stress biomarkers than methamphetamine administration. And they used relative doses that humans would use if they were abusing the drug. So that kind of blew my mind, is that social instability has a stronger influence on catecholamine levels than direct methamphetamine administration. So this is just this is from that same study. This is just the markers of stable condition, unstable condition, and then after they returned from that stable condition. And they were looking at interferon gamma, interleukin-6, and tumor necrosis factor alpha, some of the big players in central nervous system stress. What else does chronic stress do over time? So we know just from cohort like studies, just following people, longitudinal studies, that chronic stress puts you at risk for high blood pressure, atherosclerosis, metabolic syndrome, diabetes, infertility, immunosuppression, osteoporosis, psychopathologies, and neurodegenerative diseases. So not only are you at risk for these if you're under chronic stress over a long period of time, but even if you have other disorders, you've already been diagnosed with them, we know that stress can, even in the short term, in the acute phase, exacerbate a condition. So like inflammatory arthritis, or irritable bowel or inflammatory bowel disease, MS, Graves, psoriasis, diseases maybe you wouldn't think about right away, directly correlated to stress. So stress will exacerbate the symptoms, make them flare up. They also found in this systematic review that things like CBT, cognitive behavioral therapy, one of the treatment interventions for like psychosocial disorders, or stress reduction techniques. These help to minimize their symptoms for autoimmune diseases. And we think autoimmune is something you can't prevent, you inherit it, and it flares up and there's something you do, but they found there's a really big connection between stress and the presence of symptoms. And then let's think things on the opposite end of the spectrum. So stress is more sympathetic in nature, whereas vagal activity, vagal nerve activity, is typically correlated with parasympathetic nervous system activity. So vagal nerve activity actually reduces your risk of all these same disorders. The reason why, it's anti-inflammatory, it inhibits your sympathetic nervous system, and it reduces oxidative stress DNA damage. So that was just like the big, here's the BPS model, here's how things are interconnected. Now we're going to get into, I got to teach you about pain before we can talk about how to manage pain. So, quick intro to physiology of acute pain. What is the definition of pain? According to the International Association for the Study of Pain, it's an unpleasant sensory and emotional experience that's associated with actual or potential tissue damage and described in such terms. And then another big takeaway is that pain is always subjective. So you got to remember it's an experience. It's a multi-sensory integrative experience. Okay, so we're going to be dealing with a lot of spine pain, some acute, some chronic. So you've got to know the differences in spine pain features or ways that spine pain can present to you. So these are from Bogduck's work, Nikolai Bogduck, really big on like pathophysiology. If you want to learn like the science behind why we hurt, why we do this, that. So he kind of categorized, there's 4 different presentations of spine pain. The 4th one not really being a type of pain, but we have nociceptive pain, we have somatic referred pain, you could have radicular pain, and then radiculopathy. And we'll talk about the differences between each one. So nociceptive pain is the most common. That's that dull, achy pain. It's hard to kind of differentiate where it is. It's just kind of all over. It can be indicative of inflammation and tissue damage, but not necessarily tissue damage. And this can occur anywhere. Central nervous system, peripheral nervous system, it doesn't matter. Nociceptive pain can occur anywhere. So here's an example of different areas of nociceptive pain and how they present differently. So the most common would be a peripheral injury. So he's burning his toe. So those peripheral nociceptors, they're swimming in that inflammatory soup. So inflammatory cytokines are telling the nerve, hey, something's wrong. They're ringing the alarm bell. If nociceptive pain occurs in the central nervous system, we refer to it as central sensitization. And we'll go down that path here in a second because that's more of a chronic condition. And then if nociceptive pain is present, if these cellular mechanisms in the periphery also occur in the cortex of the brain, we get cortical reorganization, or we can also call this neuroplasticity. In the context of pain, we can call it maladaptive neuroplasticity. Okay, so somatic referred pain is another pain type. This is a type of nociceptive pain. Why do I say that? It's because it's described the same way in quality. It's dull, it's achy, it's gnawing, but it's widespread. So somatic referred pain, a lot of you just took Mackenzie over the weekend. You'll hear about the acute low back pain, but I also have pain down my leg. Is there tissue damage in the leg if there's discogenic pain referral? No. There's no damage in the leg. What's happening with somatic referred pain is, if we were to go back to that chart of the pain pathways, everything synapses at dorsal horn of the cord, right? So think of dorsal horn as like a dish full of water, and you're feeding a bunch of dogs. All the dogs can drink the water as much as they want. These dogs can be cells that represent this part of my leg, this part of my leg, my low back. They're all in that same area. So if you pour enough water in there, they're all going to get fed, right? So the somatotopic organization of the dorsal horn starts to have this bleeding effect. So there's so much pain in the low back that the nociceptive neurotransmitters, substance P, that starts to bleed over, and now we start stimulating cells that represent other parts of the body. Does that make sense? That's somatic referred pain. So prime example, cervical and lumbar discs with referral. This is a dull, achy quality, not a lancinating electric shock down the leg or electric shock down the arm. This is a dull pain. Compare that to the electric shock. That is radicular pain. So that's that lancinating, electric, very narrow, doesn't really spread. Usually patients can trace it with one finger where they feel it. Again, it doesn't refer to a dermatomal pattern necessarily, and it does not require sensory motor deficit. So radicular pain is think of the acute disc injury, and there's so much inflammation at this dorsal root ganglion, the DRG, that it spontaneously fires, right? Nervous system structures fire more easily when they're inflamed, right? So the threshold has been lowered, the DRG fires, and they experience pain down the leg. Again, no tissue damage in the leg, It's a neurological phenomenon. Last one is radiculopathy. It's really important that you separate out radiculopathy from radicular pain. Radiculopathy in and of itself is a sensory motor deficit. This is when someone has myotomal weakness or dermatomal numbness or paresthesias and deep tendon reflexes are diminished. So lower motor neuron signs. This is why we test DTRs on everybody as a screen, because you immediately get, did they have a sensation, did they feel it, and did they have a motor response? And was that motor response aberrant in any fashion? So that being said, and here's the picture of radiculopathy. It has to be compressive in nature. There are non-compressive radiculopathies, not as common, but radiculopathy, there's compression of the nerve root to the extent that it cannot fire action potentials. Radicular pain, going back, that's when it's just, maybe it's not being compressed, but it's inflamed, so it fires too easily. So I really want to just hammer that home, because as a lot of you are approaching clinics, and that's something you really have to identify differently, because knowing what they're describing to you or what presentation this patient is, giving you information about, that tells you physiologically what's happening to them, and it can change prognosis. So it's important also to remember that combinations of these can and they do occur. So in this picture here, it's an acute disc herniation. There's a lot of inflammatory action occurring here, and there's compression. So maybe this person has radiculopathy, sensory motor deficit, and they also have radicular pain shooting down the leg every once in a while, intermittently. And to add to that, this disc, because it's inflamed, maybe they're feeling nociceptive low back pain, dull achy pain in the back, sensory motor deficit, intermittent shooting down the leg. Those are all 3 different pain presentation types. All right, so last point, this little bottom one here. No more using the word sciatica, ever. Never, ever, ever. You'll see it in notes from other docs.
What about billion doc?
No. No. Never use the word sciatica. It doesn't tell you anything. If someone asked me in a job interview that I did not ask for, said, well, what do you do with a patient with low back pain and sciatica? What does sciatica mean? No one knows. So be more descriptive. You guys are spine experts. So I really want you to, hopefully that helped you understand those 4 different terms. You can use them more easily now. So that's acute pain. Just a quick little spiel there. The rest of this talk, we're going to focus a lot on chronic pain. Why? Because a lot of acute pain gets better on its own no matter what you do to them. No matter what techniques you apply, no matter what fairy dust you sprinkle on them, it gets better. Chronic pain is something you guys got to get really good at treating. So first of all, definition. Chronic pain is described or defined as pain that persists past normal healing time. So maybe there's acute injury, tissue's healed, they still feel pain. I bolded this word for emphasis, and we're going to talk a lot about this. It's the inability to extinguish the memory of pain from initial injury. Chronic pain is pain that lasts longer than 3 to 6 months. 1 in 5 people that enter your clinic are going to be chronic pain patients, unless you advertise or market discreetly. So it's there, it's around, it's very common. And we have really poor skills at treating it. There's subtypes of chronic pain. We're not going to go into all of them. The main one is chronic primary pain. Chronic primary pain is when there's 1 or more regions in pain. Pain's been there for longer than 3 months, like we said. And then these next 2 are really important. There's an emotional distress or a functional disability, and this pain interferes with the person's ability to live the life they want to live. They can't go out with friends, they can't sit at the dinner table because it hurts too much to sit, causes anxiety, or it frustrates them because they can't get rid of the pain. So examples would be non-specific low back pain, so there's no organic cause, it's just there. Chronic regional pain syndrome, fibromyalgia, or IBS, irritable bowel syndrome. The rest I'm going to skip through just in the interest of time. Just keep in mind there are different types of chronic pain. We might also see chronic musculoskeletal pain, So OA would be a good example of that. There is a physical cause of the pain that will not go away. So OAs makes sense. The joint, no matter what you do, every time you move it, you're going to cause irritation and inflammation. But the risk factors and the genesis of chronic pain, this is where I really wanted to hammer home a lot of good points that I hope you'll learn from. So starting with general psychosocial constructs, these are what we call vulnerability factors. So the more of these that a person has that make up like their characteristic traits, the greater risk they have of developing a chronic pain syndrome. So there's affective disorders, anxiety, depression, negative affect. You can even be overly optimistic or have positive affect to the point where you are at risk for chronic pain. There's trauma. So the amount of pain you experience in the initial insult has a good influence on chronic pain development. So traumatic brain injury, pretty big deal. If you stub your toe tomorrow, are you going to think about it for the next 5 years? No. But TBI is a big deal. PTSD, so a psychosocial or psychological trauma. There's social and interpersonal, there's sex-related, there's race-related. But just breezing through this list, you've seen all these words, you've seen these buzz terms before. These all put you at risk of developing a chronic pain disorder. Then there's pain-specific psychosocial constructs. So these are the ways you act after you experience pain. So someone who's currently in pain, these are some of the 5 things that you need to look for in clinic that would cause them in their pain state to persist, right? Because they're coming to you, they're already in pain. So one of the first things you do in a new patient exam is you screen for yellow flags, right? You've heard that term. You're analyzing this person and you're looking for, okay, is this pain going to go away on its own due to its natural history the way it should? Or is there any reason why it might stick around? And these are the reasons why it might stick around. So altered central nervous system pathways. This is like your central sensitization, which we still haven't really talked about yet. But they have a hypersensitivity to pain. Catastrophizing thoughts. Oh, it's never going to get any better. This is the worst thing that's ever happened to me. Coping. Oh, I'll just go drink a beer and worry about it tomorrow. They don't really ever do anything about it. Expectations. So maybe they don't expect it to get better. Oh yeah, my mom had the sciatica and it never went away. It's probably never going to go away from me. And then self-efficacy. They have no confidence in their ability to overcome this pain. So confidence could be interchanged with self-efficacy there. This is from a book I'm writing. Thought I'd selfishly plug that. This is a table. So this is a different way to categorize flags. So you guys have probably gotten used to the terms red flags and yellow flags. But you could categorize them even further into orange, blue, and black. Basically, we know what red flags are. Those are the scary things you send out for. Orange flags, psychiatric symptoms that have a true diagnosis, like clinical depression or personality disorder. Why do these need their own category? Because orange flags are things that you typically need to co-manage. Don't try to take this on your own. This is usually when the depression itself or the personality disorder itself is the main thing this person is dealing with, and the pain is like a side effect. Yellow flags, flip it. So mostly they're dealing with pain. They have a little bit of an affect or a behavioral component that kind of makes you uneasy. Blue flags, perceptions about the relationship between work and health. So social injustice, or I work in an unsupportive environment. My boss doesn't care if I get hurt. Those kinds of things. And then black flags are system or contextual. So that could be legislative and things like, oh, like I'm never going to get reimbursed, or like PI cases. And, they hit me, like I'm the one suffering. They're not doing anything about it. So there's these scenarios where pain might persist due to their behaviors and their reactions to what happened to them. All right, so Bland's model of the vicious cycle. This is the vicious cycle that we use to explain why pain persists. And I want you to focus on the central component of it. So you have your injury here, right? You have your pain experience. This is something that happens every day or every week to us. Little injury, big injury. But what separates us from this vicious cycle of chronicity from this, normal average route to recovery is the presence of fear, right? So that's a big take home. fear is the central component of chronifying pain. So a person gets hurt, they think, oh, worst thing's ever happened to me, they have this negative affect, they have pain-related fear. So now they're like, oh, I don't want to use my arm anymore. I have so much fear that I avoid things. I don't use my arm as much. I'm always like picking at it and rubbing it, like, oh God, why does it still hurt? And that's just making it worse. And then it gets this disuse, depression, disability phase, where, oh, my shoulder's just, you always hear that someone said, I got this bum knee, or I got this, this bad hip, or this bad whatever. They see it as it's broken, it's never going to get better. And the only way to break this cycle is the removal of fear in confronting, confrontation, or taking active approaches to getting rid of this pain. Another diagram. So this is all of what you're looking at is all of the cortical and subcortical regions that integrate pain. Everything in red, this is all dealing with the sensory coding of pain, meaning I hurt at this intensity in this precise location with this quality of pain or perception. Everything in blue, all these structures are involved in the memory and emotional response to pain. So you'll notice right away they're bridged, so they're interrelated. You can't really have one without the other. But an important take home that we kind of mentioned earlier is that everything in blue is what predominates chronic pain. It's the memory of the pain and the fear-related emotions that go with pain. Those are the ones that cause persistence. That being said, I did find this random study one day, and it had to go in here, because I didn't know this either. But there is an anatomical predisposition to pain based on the size of your amygdala and your hippocampus. So what does the amygdala do? If in 1 to 3 words, what is its role?
The alarm center.
Alarm center, or emotional responses, right? So having a small amygdala means you're less able to react appropriately with emotion to any sort of stimulus. So they found that people with smaller amygdalas, it predicted chronifying pain. Same thing with the hippocampus. What's the hippocampus's main job in one word? Memory, learning. So they found that a large hippocampus had a higher fear contingency awareness, and it was better able to discriminate contextual fear. So what that means is people with large hippocampi, they're better able to stop and say, am I overreacting? Or is this the way I should be overreacting, or the way I should be reacting? So anyway, just a cool takeaway that now that we can, scan the brain like it's nothing, they are finding that there is an anatomical predisposition.
Do you think that's like congenital, like they're born that way, or like through neuroplasticity of just their personality, that's the way that they are?
I think both play a role. I think in the first 8 to 10 years of life, everything this person experiences matters. Plays a large role in plastic change in the brain. But we also know plasticity happens on a day-to-day basis. So yeah, I think that's a good question. I think both answers would probably play a role. Because we see all these different areas of the brain too. If you guys have read of Norman Doidge's book, The Brain That Changes Itself, or The Brain's Way of Healing, crazy things can happen with practice and persistence. So small areas can get larger, large areas can get smaller. You can really change the brain. So yeah, that's a good question. But this could just be a representation of their current state, the way they act.
Do you usually find, like, from your experience so far, that like certain chronic pain patients do typically have like less of a go-getter mentality?
Absolutely. Yeah, and this maybe I should have made this point earlier. We saw a huge list of all these different yellow flags and orange flags that can contribute, and every one of those paints a different picture when you're looking at a patient. Like, every patient is a completely different story based on each of those words. But yes, you will see a lot of them have no self-efficacy. They don't want to take care of themselves. They come in, they lay down, and they say, fix me. And then there's others, they try, they work really hard, and the results just come so slow that you just do your best to keep motivating. So, yeah, good question. I'm not going to go down this rabbit hole entirely, but it's important to kind of give you a quick intro to it. So we're talking about neuroplasticity, and changes in the brain happen on a day-to-day basis. What they find in chronic pain is that there's like this pseudo-atrophy of the medial prefrontal cortex. Among other brain regions, this is the central hub of where most atrophy in the brain occurs in chronic pain. So you can see this bulleted list, that's all of its functions. So we already get a diminishment of its function that we can tell would contribute to chronic pain. Medial prefrontal helps in decision making, executive control, conflict monitoring. So we talked about the alarm system, conflict monitoring, error detection, learning and memory, and emotional processing. So there's two major functions that cause this to atrophy in the first place, and that's glial activation, which is also known as neuroinflammation. So anytime you threaten the nervous system at all, there's an inflammatory response, just like the peripheral tissue of the body. And then the other underlying chronic system that's at play is the HPA axis. So what does HPA stand for? The hypothalamic pituitary adrenal axis. So your endocrine alarm system, your endocrine stress response system. So now you've got an endocrine system that's chronically active, and you've got a nervous system that's chronically active, specifically the sympathetic nervous system. Both of these just go hand in hand and just tear apart the brain, especially in the medial prefrontal cortex. There's retraction of dendrites, so there's less functional connectivity. There's diminished perfusion, and you can see this on fMRIs or just MRIs. There's decreased signal. There's less fatty tissue. It's just not a healthy part of the brain anymore. So yeah, we won't talk too much about glial activation and neuroinflammation. This is part of the section I took out. But there's one thing I do want you to realize is that it's completely normal for an inflammatory response in the CNS to occur when there's a threat to the system, right? You've got to have inflammation to overcome adversity. The problem that I bolded is that pathogenesis lies in failure to resolve in the post-acute or early chronic stage. So we just slip into this cycle that never ends. Physiologically, psychologically, all the above. We're just in this chronic cycle. So yeah, you don't need to know that. This is all Kettner stuff, so if you understand why it's hard to read. But neuroinflammation occurs in like all these other different conditions. So if it occurred in M1, the motor cortex, you see that in ALS. If it occurs kind of throughout the white matter, we call it MS. If it's in amyloid-positive regions, which is part of the basal ganglia, we call it Alzheimer's disease. I'm sorry, I skipped a step. Amyloid-positive regions, that's like the basal nucleus of minor, the one that creates acetylcholine in the memory pathways you learned about Neuro 2. Basal ganglia, if we have neuroinflammation there, that's Huntington's disease. And then HIV encephalitis, ischemia, and the cingulate cortex, these are all different areas where neuroinflammation can occur, and all you get is a different manifestation, different characteristics. But it's all the same underlying mechanism. Right? So fibromyalgia is another chronic neurological disorder, and the reason it's poorly understood is that it's kind of spread throughout the entire brain, just a little bit of neuroinflammation everywhere. So how does that manifest? Well, we get widespread musculoskeletal pain, fatigue, unrefreshing sleep, memory and attention difficulties, among others. So the reason I brought this up is that chronic pain is no different. Chronic pain ends up becoming a cortical reorganization in a neuroinflammatory state, but it's specific to S1, M1, and paracentral lobule. So it's specific to the areas that somatotopically represent the painful body region. So if I have chronic shoulder pain, S1 that represents my right shoulder is going to become inflamed over time if I don't stop this cycle. And that just perpetuates it, makes it harder, because what did I say about nervous system structures if they're inflamed? They fire more easily. They're sensitized. So don't look at chronic pain. It's not just this like, oh, they're just faking it, or oh, they need to address their emotional issues. It becomes a physiological phenomenon too in their brain. No different than fibromyalgia. The only difference is the location. So chronic pain, it's only going to be in areas consistent with the somatotopic representation of, in this case, chronic low back pain, so in the back and the leg. Fibromyalgia, it's widespread, it's everywhere. All right, so how do we treat this? That's really cool. We know all about inflammation and stuff. First, one more little cycle image. I've seen enough of them. But in the middle, you'll see that the red, that's like your perpetuating cycle. That's what causes constant chronifying pain. So the person has Pavlovian conditioning. So they associate certain things with their pain, and then they just remember them. We have operant conditioning. We have fear avoidant behaviors. So they stop doing what they love because they're in so much pain they just can't do it anymore. Ends up with physical and emotional disability. If I got so hurt that I could no longer work in a gym or exercise in a gym, I would probably become depressed too. And that just makes things worse because now there's that disuse, there's the I don't train anymore, there's atrophy and there's osteoporosis and all these factors that just take away, and it just perpetuates this whole cycle. So how do we change this, or how do we overcome this? Well, it starts up here at the top with executive control through the medial prefrontal cortex. So why did I take the time to show you all of the functional roles of the medial prefrontal cortex? That's our entrance, like that's our way in. So I'm going to go back and show you this list. Decision making, executive control, conflict monitoring, error detection, learning and memory, and emotional processing. Those are the cortical functions you've got to address. You've got to get working, right? Because the more we use certain areas of the brain, the stronger it becomes, right? There's use it or lose it, and then whatever the opposite of that would be. So that's how we start this positivity cycle of overcoming chronic pain. We can decrease threat perception. Remember I said fear is that central component of chronifying pain. So if we can teach them hurt does not equal harm, and they, okay, yeah, I'm not scared anymore, I can move. Okay, a little bit of pain's okay, I'm not afraid of that. You reduce avoidant behaviors because now they're willing to give it another try to do their exercises. Increase functional capacity, and you taught the patient to conquer the pain. So I thought that would be fitting, but anyway, no spoilers. So a few guidelines are already out there, and they're already telling us to do this. And I just wanted to show you this one more time before I kind of give you my impression of how we address chronic pain. But the American College of Physicians, they've already got recommendations. So in the acute and subacute setting for pain, what do they recommend? Superficial heat, massage, acupuncture, spinal manipulation. Acute pain usually going to get better on its own. There's nothing you really need to do. The less is more in these scenarios. What do they say for chronic pain? They say, let's give them exercise, multidisciplinary rehab, acupuncture, mindfulness-based stress reduction, Tai Chi, yoga, motor control exercise, progressive relaxation, biofeedback, laser, operant therapy, CBT, manipulation. Of this list, how many of these recommended interventions are things the patient does for themselves versus how many things you do for the patient? That's the big thing I want you to realize here. So we can do some spinal manipulation. What else can we do for them? We can give them low-level laser. I feel like biofeedback's a passive modality, but I don't even know the nature of what it is. But a lot of these are active care. It's something you get the patient doing on their own. That's important. All right. From Nidges is an author who, if you want to learn anything, if you just want to understand pain, start with him. But he said in all three pain types, a biopsychosocial view is warranted. In all three pain types, a multimodal model is necessary to explain the pain and to choose the appropriate treatment. That's why I took the time to teach you the different types of pain and the pain features in the acute setting. It's because you've got to understand it before you can determine how to treat. Last one, this is from those Logan grads that rocked this paper. The shared aim of the psychosocial interventions are to galvanize active patient involvement in healthy lifestyle behavior, empower the patient to lead a lifestyle that holds greater self-efficacy, and reduce the need for dependence on you. So the main aim of chronic pain intervention is empower them, educate them, tell them, no, you can do this. Like motivate them in any way possible and get them to take back their own health. So I really want to emphasize this paper. It came out in February this year. It's a systematic review of all the current clinical practice guidelines. So of all the guidelines out there that are recommending how you take care of a musculoskeletal pain patient, they looked at all the correlating factors in every single paper, and they came up with a list of 11 things that you need to include in every single patient encounter. So you need to be patient-centered, you got to screen for red flags, you got to do some form of psychosocial assessment, image wisely, so we don't x-ray everybody, but we determine when to do that. Perform a physical exam, utilize OATs. What are OATs?
Objective assessment.
Outcome assessment tools. So those are like your questionnaires. I don't want to go down the whole rabbit hole there, but like questionnaires are some of the best things you can use for a reevaluation. I don't care if the patient's pain intensity remains a 5 out of 10, but if their functional scores increase or their disability scores decrease, that's a win. So outcome assessment tools are something I wish we had like a class on or something, but look into them. And if you want to know like what we use at Affinia too, I'll let you in on that. But you also have to educate and empower the patient, and then provide active care, and then I like this one here, passive care as an adjunct. So we use, like, spinal manipulation is like the center of our identity, which it shouldn't be, but it is. It's passive care. If it's the only thing you're doing, I'm sorry, but you're not being an evidence-informed provider. So it should only be used if you're going to follow up with something else. And Frizzy does a great job teaching you guys like the effects of the adjustment and the power behind it. But what does he say after he explains all that? Okay, what are you going to do next? What are you going to give them rehab? Or are you going to, what are you going to do with them after the passive care? And then the conservative care before surgery, that's obvious. We are conservative care, so no biggie there. And then return to work. So you always need to encourage people to return to work. So I saw a patient with an acute low back strain sprain, not a big deal at all. His nurse practitioner told him to take work off. He took 3 weeks off and just sat on the couch. Remember, this guy is below the poverty line. Every day he takes off is a big deal. So yeah, rule number 1, keep working, stay active. All right, so here's my cool little picture I worked on for a while. This encompasses every component of evidence-informed, patient-centered healthcare. Right? We've got our screening for red flags, we've got our imaging guidelines, we have our outcome assessment tools, our psychosocial risk factor, our physical exam, and then we've got the 3 components of what we do for them: education, active care, passive care. What's missing from this picture? What else do we need to consider?
Patient goals.
Thank you. The patient. So I don't care how many seminars you went to or what you think the best active care approach would be or the best passive care approach would be. At the end of the day, it's what the patient wants. So what are their expectations, their values, their goals? You'll be surprised. You'll have patients come in, and if you take the time to ask them, what can we help you for? They'll have some weird requests. Weird might not be the best word, but like not everyone's just there for pain relief. That's most of them, but a lot of them, maybe they just want to talk. All right, so anyway, starting with education, here's all the major tips I wanted to talk to you about. So starting with the first bullet, I'm not referring to where I work, which is the people below poverty line, but across the world, the average patient intelligence level is 5th grade reading level. So can you explain to them their condition without bogging them down about something about thoracic spine and the disc and the nociceptors and the blah, 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 blah? Can you very quickly and easily explain to them their condition to a 5th grader? It's something to work on. It's funny because like the smarter the clinician, the lower level I see them explaining conditions to the patients. I've worked under 5 or 6 like people filling in, all that kind of stuff. Like you'll realize like patients don't care about what you know. Explain it to them real simple, get on with it. Bullet number 2, one of the single most important bullets on this slide, something I hear in every single patient conversation, is you've got to let them know hurt and harm are not synonymous. So it's okay to have a little pain. You're not causing me any damage, I promise. That's really, really important to let them know about. And then, like the guidelines say, tell them to stay active and return to work. And again, remind them, you are not going to cause any further damage. Other things you can do for education, this is a patient-by-patient thing, but you can, teach them how to take care of themselves at home, what kind of modifications they may need to make, ergonomic, lifestyle habits, co-manage with other physicians. This is all like, again, it just depends. You'll have to make the decision for yourself. And then I had that link to Tame the Beast. Tyler did us a favor and posted it over the weekend. So if you haven't seen that video, I would recommend you watch it. I think it was 5 minutes long, give or take. Very great way to explain pain to somebody. And I had one of my first fibromyalgia patients last week. My mom has it, but it's a different story. Like, trying to explain fibromyalgia to a patient without making them think they're crazy it's a skill. Work on it, because you're probably gonna do a bad job the first time, and they're not gonna like you, and they're not gonna come back. So anyway, passive care, again, up to you guys. Just remember, this is an adjunctive intervention. So it's really not, the goal is not to alleviate their pain, it's to buy them a window of time so that they can do active care, right? So adjustments, they cause that like 30 to 60 minute window of no pain. Okay, what are you gonna do now that you have no pain? I don't know, maybe go back to moving in a painless state where you're not guarding any limbs, or you're not, moving with any compensation. But yeah, here's all your options: manipulation, mobilization, soft tissue mobilization, and then all the passive modalities. I feel like we had a really good conversation in the Facebook group a few weeks ago about someone with an acute case of like rotator cuff tendinopathy, and it flares up, and it's really like, it's just burning, that bursitis, impingement. Do you give them active care? Well, everyone's so big on active care, but is it wrong to just say, hey, yeah, also ice? It's passive. We kind of frown on passive modalities. Those who are aware of these guidelines and aware of the importance of active care, they'll say, yeah, like, I'm never going to do passive modalities. I don't need E-stim and acupuncture and light therapy, but it still has its purpose. So hopefully that conversation helped to stir up some blood a little bit, at least. And then active care, there's a few points I want to make about active care in a chronic pain patient. So you need to understand there's a difference between general exercise and specific exercises. A specific exercise is maybe in the acute setting when you have one joint that's hurting and you need to find ways to stabilize it or get it moving again, return normal ranges of motion. In the chronic pain patient, they typically have widespread pain. They typically don't have a direction of preference. They don't have any specific movement they need to perform. They just need to move. So when you first hear this, you might think that's not okay, but 90% of the patients that we see, they get prescribed bird dogs. And you're like, what? Like, not everyone, certainly not everyone, maybe there's a better exercise. No, just get them moving in any position that's not threatening. What is threatening about being horizontal to the floor? There's no weight bearing on your low back, and you're moving all of your limbs. I mean, you don't have to pick bird dogs, but you get the point. Just remember that active care, like, it's about moving, partially it's about restoring like your pain modulating system, like the descending pain inhibition system. Just getting them moving in any general direction it's going to be good for them. So that's the point I want to make. Like, I went to DNS, I went to McKinsey, I went to all these seminars and all these cool techniques, but when it comes to someone like this, it doesn't matter. Keep it simple. Also consider mind-body programs. So again, patient goals, patient values, maybe they like yoga. You'll hear a lot of patients, well, can I go do water aerobics too? I like doing that. Or can I join a yoga class? I used to do that all the time. Yeah, it's not always what you want. Like, not everyone needs belly breathing and hip uprighting and all the things that I was so biased toward at one point. A few other mind-body programs you can consider too is like progressive muscle relaxation. If you haven't heard of about that or haven't learned about that, it's something I would recommend you look into as well. Works very well. And then there's the cognitive behavioral programs. So just sitting down and addressing their mental state, or addressing head-on the fears that they have, or the social challenges that they're trying to overcome. So those are the three things you do to the patient, right? This is your way of intervening. A few other things I want you to consider, though, while you're doing this, is this subliminal conversation you're having with the patient. the things you're not directly saying, but you're trying to, you know, slide across the table to them without them noticing. So the main thing is you've got to get self-efficacy like buried into their mind. You've got to build confidence and empower the patient. And I stole this slide directly from when we gave this presentation 2 tries ago. Nick Hedges made this, but now it's mine. But you got to instill grit and growth mindset. That's a really good phrase that you'll see a lot. These 2 authors here, Marty Seligman and Angela Duckworth. If you ever if you're into self-help books at all, or if you like watching TED Talks, Angela Duckworth's TED Talk on grit, very great video to watch. But even if we need research to support what we're saying, like higher self-efficacy levels are associated with greater physical function, physical activity participation, health status, work status, satisfaction with performance, efficacy beliefs, lower levels of pain intensity, disability, disease activity, depressive symptoms, presence of tender points, fatigue, and presenteeism. All that just based on higher self-efficacy levels, confidence in their ability to overcome whatever they're going through on their own. Subtle reminder, obviously we're not going to go through this list, but reminder that in these patients you're dealing with a lot. They have a lot of baggage. And so don't forget, you're the chiropractic physician. You do the musculoskeletal pain stuff. You're not necessarily a psychiatrist. So realize the difference between like an orange flag and a yellow flag. Orange flags need to be addressed with somebody else, okay? I've had a patient say the words, "This pain's so bad that like I literally have suicidal thoughts sometimes." And I immediately was like, okay, this is not for us. We can treat, but we're also going to send you to behavioral health, because that is more important, right? So don't forget you're not alone. This is a little tangent we went on a couple trimesters ago. It was a little debate I had with a couple close friends. What does wearing a white coat or not wearing a white coat in practice, what does that do for patients like this? Is there a right or wrong? Should you wear one, should you not? Immediate answer is that there have been surveys out there, and patients either have no preference or they do prefer the white coat with a button-up or scrubs. They don't really care if it's a button-up or scrubs under it, but no one says, yes, please give me a doctor wearing a polo. It's either I don't care or I do like the white coat, so just so you know. But what are like the pros to wearing a white coat? Social image. So you look smarter. You look like that person that went to school, and you have clinical competency. And so it helps you, I just want you to remember, like, you're going to be a doctor. Like, doctor is like the highest status there is anyway. In most states, it's physician. Colorado just said you can call yourself a physician, finally. So it's an appeal to authority too. So the patient sees you and they immediately think, okay, whatever this person has to say, I'm going to listen, and I trust this person. So think about the picture you paint in their mind. If you walk in and imagine if you're wearing a shirt like this, that it's untucked and, like sweaty and ugly, versus like a pristine white coat, like the textbook doctor. I know it's like, we want to look comfortable, we want to look like that active care person, but consider what message you're passing on to your patient. So then what are the cons to wearing a white coat? Well, chronic pain patients have been around the block. They've been to many clinics, hospitals, etc. Maybe they associate the white coat with failure. Maybe every other person they've met in their lives were wearing white coat and they came back with negative results, or I can't help you, etc. So maybe you do need to look different. And then I was shadowing Josh Browning, who was here last Friday. He doesn't wear white coats in front of children, like anyone below the age of like 15, 16, but he does around everyone else. So there's also the adolescents, and you got to take that in consideration as well, because their heart rate increases way higher than the adult does when they see a white coat. So little things like that can go a long way. But kind of going back to the main point, maybe they associate the white coat with failure. So maybe you want to be that amazing doctor they've never seen. Maybe you do want to be different. So you would have to kind of paint your own image and look different from the rest. So yeah, I don't really have a right or wrong. That was just like the answers on either side of the fence when we talked about it last. You have a question?
I didn't know if I could comment. But
Sure.
Granted that
I was listening to a functional neurology podcast. I don't remember what it was, but it was a little blurb, and it was about white coats and how essentially this patient had this ongoing issue, and kept saying, oh, but my doctor did this, or my doctor said this and that. And so this clinician was having such a difficult time with her, explaining, like, you're okay, it's going to be okay. He literally went to his office and then threw on his white coat and said, look, like, I'm a doctor too, and this is going to be okay for you. So that's what it brought up in my head. So,
Makes
yeah,
a good point.
Yeah, I think it can be used case basis. You know,
Yeah.
if you have, I don't have a beard, so I'm going to look younger, so I might need to look a little more,
Right.
you know, but you got some years on you. But yeah, no, I think that's awesome. So I just wanted to share that.
Yeah.
That's pretty cool.
A couple trimesters ago too, I ran this presentation by Dr. Huber and kind of got his input on this too. And he said, well, why not take it a step further? Maybe on the first day, the new patient exam, you find yourself wearing it. But then, you know, 3 or 4 days later, maybe, oh, I forgot to wear it. I don't wear it anymore because we've built this relationship and you seem a little more comfortable on their level. So things to consider. It's a pretty good tactic. Could go a long way. All right, so last little section. I know it's been a long conversation already, but I did throw in a couple case studies, and these are patients that I have seen at Affinia, and they were, like I said, moments of personal growth. And I wanted to pass this on to you guys because there's no way for you guys to be any better than like the people in my class than if we passed on our knowledge ahead of time, so that you're more prepared than we were when we first entered clinic. So hopefully if I give you a few case studies, a few things to take away, that you'll already be ready for that, and you'll you know, hopefully get on my shoulders and we'll go a little higher there. So first case, 59-year-old African-American female. She came in with pain in many regions. Mostly it was the back of the neck, like kind of around the shoulders bilaterally, T-spine. She was in a car accident 3 weeks ago. And I asked her, well, what makes the pain worse? And she said stress. That was it. I said, okay, anything that you found that helps it feel better? She goes, yeah, just moving around feels better, drinking warm liquids, and neurologically, drinking anything or eating anything is parasympathetic stim. Quality, achy pain. She said it's kind of spreading. This pain's spreading down all 4 extremities. It's getting worse every day. 8 out of 10. But she wasn't in distress. She was just there having a conversation with me. The main thing, though, she said it's not really causing her any disability, but she had a previous stroke. So this is where we get into like a really deep medical history. She had had a stroke before. If you look down here at the past medical history, she also had a brain tumor that disappeared inconclusively. Like, we don't know what happened. It's just, she had a follow-up image. It's gone now. Should I be happy? I don't know. She also had a history of a pelvic tumor. So she's been around and she's had some things happen to her. She also, both her mother and her grandmother passed away of a ruptured aneurysm. And she had like this deep fear that she would have one too. So she was uneasy. So her goals, I asked her, like, what can we do for you? Is this just pain relief? Is there something else? And she said, you know, really, I've never really talked to anyone before. You know, she said, I feel so sad and anxious. Like, she basically just put it on a silver platter for me and slid it over and said, I'm depressed, I want you to send me to behavioral health. I didn't have to like go looking for it. She just said, I'm sad. Every day I'm sad. I just want someone to talk to. And she also, she wants to get a little better. She wants to restore functional capacity. Social information, pretty important. She lives alone. Her daughters, she has 2 daughters. I'll tell you a story in a second. So she feels isolated and she's scared to walk outside because she walks in a pretty bad neighborhood where if she looked weak or fragile in any way, that she would be afraid for her life or her well-being. She has 2 daughters, both 20s or 30s. Back when she had a stroke, she called one of them and said, hey, I had a stroke, I need you to come take care of me, you know, take me to rehab, blah, blah, blah. Mom, I'm busy, don't ever call me again. She didn't even want to call the other daughter because they had an even worse relationship. But a couple days later, she couldn't afford rehab. She's just healing on her own from the stroke at home. She had a fall in her bedroom. She had to crawl down a flight of stairs, pull the phone off the coffee table, It shattered into 3 pieces. She held all 3 pieces together, called the other daughter she didn't even want to call. She said, hey, like I fell, I can't get up, I'm hurt, half my body's not even working right now, I had a stroke by the way. And she again said, Mom, please do not ever call me again. Do you think there's a psychosocial component to her pain? Yeah. So yeah, mental health history. She openly expressed depression and anxiety. She said that she's had such bad anxiety since the car accident that she's had diarrhea every single day without one day off. She has stomach pain, she's not right, she's shaky, she's just scared and twitchy. You can see it in her presentation. Okay. These are all the red flags she claimed. She said yes to. Bowel bladder dysfunction, I need to soften that. That was not true bowel bladder dysfunction, that's based on the anxiety. She had a sensory motor deficit. She was talking about numbness and tingling in all of her fingertips. Recent significant trauma, obviously she was in a car accident. Ever since the car accident, she's had headaches that are worst headaches she's ever had. They're so bad. She had visual changes. She's getting dizzy. She says like she'll have like tunnel vision and then she'll collapse. So she's had fainting and near fainting spells. And then the abdominal pain again. So this was a tough case. So what do we do after we take a history is we assess for yellow flags. So we gave her a questionnaire. I threw this in there because I really want you guys to learn about the start back. If you haven't heard about the Keel start back, you should all be using it in your clinic one day. It's only 9 questions. It's K-E-E-L-E, Keel start back. It's only 9 questions. The first 4 questions ask about the intensity of the pain or the pain symptoms themselves. We talked about all the different things that contribute to a chronifying pain condition. Part of it was the intensity of the initial pain. The next questions, 5 through 9, which is what we count up as a sub-score. Each question individually assesses for, does this patient have fear? Do they have anxiety? Do they have catastrophizing thoughts? Are they suffering from depressive symptoms? And how bothersome is this condition? So you can take a total score from these 9 questions, and that gives you a decent understanding of what risk category they'd be in. And you can take the sub-score, that's all psychosocial factors embedded in there, and that can give you more of a psychosocial risk factor. So she was 9 out of 9 and 5 out of 5. High risk. So we did our physical exam. Really not much with the physical exam. So inspection, I could have put that she walked with a cane and she was hunched over, but not so relevant compared to everything else. Palpatory tenderness, obviously. She had guarding and muscle fear avoidance in like all directions when she moved. She just didn't want to move, quite honestly. And the only pertinent neuro finding was because she'd had a history of a stroke, she had an inverted supinator sign. So I did her biceps and brachioradialis reflex, and she went like that. It's pretty cool. Okay, so anyone want to try this one? What are you going to do with her? Someone give me a recommendation. What do you want to do with this patient?
Educator, first and foremost.
Okay, yeah.
Try to let her know, like, hey, I understand you're coming in with all these things, but based on what I'm seeing in my exam, you're not in any extreme danger.
Sure.
We're here to help you, support you in any way.
Yeah, that's a great answer. Thank you for offering that. Hopefully I structured my presentation in the right linear order where I want you to realize that the first thing you should ask yourself after every new patient exam is you go back to what were the patient's values and expectations and goals. And again, we'll get to that in a second. We did talk and we did make great friends and she loved us for it. But the very first thing she told me is, I'm feeling down and depressed and I want to talk to somebody. So the first thing we did is we sent her to mental health. We immediately, I mean, not like once this conversation is over, I'll go and get someone. Like we had someone in-house, and while I was talking with her, Battaglia went and got behavioral health and escorted them to the room. So that's how pressing some of these issues can be. Yeah.
You can go ahead.
How do you communicate that to a patient without being offensive almost and like saying, oh, you need to go see a mental health specialist when they're coming towards you and not going straight towards a psychologist or
Sure.
psychiatrist?
In her case, it was, like I said, it was easy because she said she wanted
Yeah.
to, but in other cases, that's just part of like the history. So here's the way I word it every time I've gotten like in the habit. I'll say, I got a few other questions for you. Don't be alarmed by the nature of the question. We ask everybody this. And I say, do you have a history of anxiety, depression, or post-traumatic stress disorder? And a lot of times they'll say, oh yeah, like a few years ago, someone passed away or something like that. But a lot of times you'll get it out of them and you can tell that they're suffering. And you just say, have you ever considered talking to someone, or do you want us to refer you to talk to someone? Just throwing it out there, they can throw it right back or they can accept it. It's totally up to them at the end of the day. But yeah, it's as simple as just giving them the option. Do you want to talk to somebody? I don't think I've ever had anyone who took it wrongly. So what else do we do? Well, like I said, we are neuromusculoskeletal specialists. We do hands-on therapy, so we did manual therapy. So I mean, with the amount of pressure you can apply to your eye, we did just ischemic compression to her upper traps. That's essentially it. That's all you could do. Any more than that, it was too much. And this is one of those cases where that phrase, like the healing power of touch, like true skin-on-skin contact with someone you've created a relationship with, it goes a long way. So don't get too caught up in like all the fancy tools and like tables and things you can do and bands and tape. Just touching someone with your own hands, that can heal them more than anything. And then we sent her home with progressive muscle relaxation exercises, and she was all for it. She came back the next 2 weeks later, and she had done them every day, and she was so happy to show us how good she was at it. So if you aren't familiar with PMR, it's basically, we gave her a sheet and an order of exercises to do, but you work on contracting a muscle as hard as you can for 5 to 8 seconds, and then for like 3 to 5 seconds, you let it relax entirely. And you just work up your body, starting with the toes, curling them up, then the ankle. You work your way up. So it's really good for anxiety patients. It's just learning to get motor control of their body and teaching them how to relax. Because anxiety patients, they're like this, and then they get acidic buildup and muscle pain. Teaching them how to relax is a good way to get started with them. And it's active care. She took care of herself, and we didn't have to see her for 2 weeks. She came back, she was feeling so much better, and she was happy. She was like, oh, I'll show you my exercises. I'm doing them every day. So yeah, that was that case. I hadn't edited my PowerPoint since I had seen her last, but I have seen her since. She's doing way better, and really, if you think about it, we didn't do much to her. It's what we offered her options to do, and something we gave her to take home and do. The amount of pressure and the amount of time I was touching her was very minimal. All right, there's only 2 cases, last one here. 53-year-old African-American female. She complains of post-operative thigh and leg pain. So she had 3 years of what she called sciatica. I don't know, but she got a microdiscectomy a couple months ago, I think in February, but she had persistent leg pain, even though she had had the surgery. Does that surprise anybody? The memory of the pain was still there. After 3 years of constant pain down the leg, she got the surgery, still had pain down the leg. So about 2 weeks after her microdiscectomy, she started feeling the pain coming back. She said provocative, well, movement's provocative, but walking is palliative. It was kind of a weird, I don't know, she was afraid to move her low back, so I wanted to say low back movements were provocative, but walking felt good. She described it as a cramping feeling, and we'll talk about what that indicates. But it's down the right lateral thigh. She also had some numbness in the 4th and 5th digit. Very common post-surgically. It might come back, might not, who knows. 9 out of 10 pain, and she was definitely in distress. This person was crying during the history out of fear, because she wanted to know. She said at one point she was like laying down, she might have heard a pop, she doesn't know, but she thinks maybe like the jelly's back out of the donut, or the surgery, like the surgical stitches are gone. She didn't know what happened during the surgery or what kind of procedure it was. She didn't realize it was like a hole that big, and they just went in. And she thought maybe she was, opened up. So yeah, she was scared. Tears in her eyes as she gave the history to me. And I asked her, is this pain causing you to? Are you avoiding anything, or is there anything you're not doing out of fear of making the pain worse? And she said, yeah, I don't want to play with my grandkids. I don't feel like I can pick them up. I'm not strong enough, or I might damage something back there. And so her goals I considered was she just wanted understanding. She wanted to know what was wrong with her back and her leg, why it was still there. She works somewhere where she requires heavy lifting, so she hasn't been doing that either. Social history, not necessarily pertinent, but she did claim she had anxiety, and her blood pressure the day of the history was like 170 systolic. And she's never had high blood pressure before. This all happened after the surgery, after the fear started to instill in her. Denies any prior treatments, and yeah, past medical history was just the surgery and the 3 years of radicular leg pain prior to the surgery. Red flag, sensory motor deficit, and orthopedic surgery. So, self-explanatory from the history. So, like we do with every patient, we screened her for yellow flags, gave her a start back. She scored a 7 out of 9 total, but a 5 out of 5 on the sub-score, meaning she had all of these: fear, anxiety, catastrophizing depression, and bothersomeness. She's a high-risk patient for chronic pain if handled incorrectly. Exam, gait was normal, heel toe, tandem gait, all that was normal, no Romberg in tandem stance, figure in the nose, rapid alternating movements within normal limits, all reflexes 2+, no clonus or pathological reflex, upper and lower extremity vibration sense within normal limits, muscle tone normal, hand and bulk strength, hand bulk and strength normal bilaterally. Inspection, all she had was a surgical scar. Basically everything else we did on her was normal. Nothing really provoked it. Including general ranges of motion, which at one point I told her, touch your toes. No problem, she could touch her toes. She could flex her spine. So what do you do next? Who's up? She's just really afraid. She wants to know what's going on. She obviously has full function from her orthopedic exam. What are you going to do?
Patient education on like what type of surgery she had, the memory of the pain, catastrophizing, yeah.
Exactly. Yeah, patient education came first, right away. Okay? So here's what we did. We educated. We spent a lot of time telling her, hey, the surgery you had, it was nothing huge. That's the scar you have, it's really small. All they went in and they did this and this. There weren't even any stitches. There's no such thing as the jelly's coming back out of the donut in your situation. That's not possible. So we let her know what she's not experiencing or what's not happening to her. So that gave her so much relief, she started crying tears of joy. We watched the patient cry tears of fear and tears of joy in the same hour. Pretty huge. But also, like, what are we going to do about this pain? It's still there, it's real. So how do you treat this kind of pain? It's persistent, painful memory after 3 years of sciatic pain.
Don't forget rid of the fear avoidance.
Again, so I'll add to that. She was afraid of what was happening to her. She had verbally, she expressed fear of what's wrong inside of me, but she did not have any fear avoidance in her orthopedic exam. She wasn't doing this or moving around. Like, she was moving like fine, which was weird. But yeah, in that case, if she was fear avoidant, you would want to address that, but she was not. So we did give her exercises, but I want to know who wants to take a stab at what the best exercise would be in this case.
Anything that resembles picking up a child, or show her that she can.
Yeah. What about the fact that she had persistent radicular pain? You guys know of any
Mindfulness, maybe? I guess.
nerve-based exercises?
Nerve flossing.
Sciatic nerve flossing, okay. That's what I wanted to give her. So we're in the same boat, say no. But that was a bad answer. I'm going to tell you why. You wouldn't know, I didn't know. I had to ask after, because the way it works is we do the history in ortho and then he comes in and makes the decisions. He prescribed her bird dogs. Why? Well, there is a component in nerve flossing, just not like full range motion. And she's just rehabbing from microdiscectomy. More than anything, we're just getting her moving. We're making sure multifidus doesn't atrophy, like those kinds of things. But I do want to, I set you up for that on purpose, because I feel like a lot of people would think this is the perfect nerve flossing candidate, right? Because who do you give neurodynamic exercises to? People in the subacute and chronic pain phase. So nerve flossing doesn't really work in the acute phase, right? It's subacute when there's fibrous adhesions occurring. But the learning point from that was that sciatic nerve pain is, it's very easily tempered with flossing waivers. So had we given that to her, it probably would have flared her up so much she would have woken up the next day, not wanted to move, hated us, and never come back. So that's just something most people just have to find out for themselves in clinic. There's another learning point from this case too, and it's called the yo-yo effect. I told you she cried tears of fear and tears of joy in the same encounter, like in front of us within 30 minutes. How emotionally driven is this person's character? Pretty easily influenced, right? So emotions are something we gotta be very careful with. So we've already cheered her up. We've already given her something that made her really happy. We told her what her pain was not coming from. These are the kinds of patients, though, that the next day, maybe they're sore from the exercises or the treatment you gave them, or they're just not feeling as good as they were at the end of yesterday. And then they get discouraged, and then they get sad again, and then they give up. So this is that yo-yo effect. It's like you can cheer them up, you get them feeling like this, you high five, you hug. She hugged both of us. She was happy. She left there like best day of her life in the last 3 years. She told us, I haven't been to a doctor in 10 years because they're all a-holes and I've never liked anyone but you guys, and it was awesome. But be aware, these kinds of patients, you gotta stay stoic. You gotta, have that steady mindset, and you gotta remember that you're not always gonna be up here emotionally. There's gonna be, you're gonna easily get discouraged too. So it's good to like keep that neutral head state, so your patients aren't drifting too far. So that was a learning point for me. Is like I felt like the best intern ever. I came in, I was like smiling, like, see what we did there? She was feeling good. And he's like, easy. Like next time you see her, don't be surprised if she's sad again and like discouraged. So anyway, yeah, that's the end of this talk. That's everything we've covered. It was a lot of information, I know. I know it took a long time to go through, but hopefully you guys took a lot from this. Again, if you ever have any other questions, please don't hesitate to reach out to me. I love talking about this concept. This is something I study all the time, and it kind of just became a passion of mine to learn about. And it's really cool when you can change the lives of people that no one else could for years. So yeah.